Hey, hello everyone. Welcome. Bevan Croft here. I co-direct the National Center on Advancing Person-Centered Practices and Systems, or NCAPS. I'll do a brief visual description to start. I am a white woman. I have long blonde hair with bangs. I am in a room with pink walls and some fairly brightly colored art, and it is very rainy outside. The window is behind me. I'm pleased to welcome you all to our September webinar titled "It's Up to Us: What Kind of Life We Want to Live, Promoting Meaningful Person-Centered Practices in Home and Community-Based Service Delivery." This webinar topic is at the core of everything that we do at NCAPS, and it also happens to be at the core of what our colleagues do who have partnered with us on this webinar at the Shirley Ryan AbilityLab, where they operate the Home and Community-Based Services Rehabilitation Research and Training Center. This is one of the NCAPS webinars where we feature research findings alongside lived experience perspectives to bring to life key issues in person-centered practices. You'll be hearing today about, and you'll be receiving lots of wisdom and lots of resources. And before we get started, I also would like to call your attention to a few NCAPS resources that you may find useful in your own work as you take these practices home with you. One is the 5 competencies for person-centered planning facilitation that we've developed, and also the person-centered practices self-assessment. These are 2 resources that were developed through NCAPS technical assistance, and Sashka will put the links to those resources into chat. You also may be interested in a series of short videos that we are proud to feature on our website that take up issues of culture and person-centered practices and the many ways that person-centered practices must reflect and honor the unique cultural identities of people who use services. So with that, we will move to the next slide. For those of you who are not familiar with NCAPS, we are thankful to be funded by the Administration for Community Living and the Centers for Medicare and Medicaid Services. And we are administered by the Human Services Research Institute, or HSRI. And we are excited to be joined by Lindsay Du Bois and her team at the Shirley Ryan AbilityLab. Next slide, please. NCAPS's overarching goal is to promote systems change that makes person-centered principles not just an aspiration, but a reality in the lives of everyone who may use services or supports at any age. So it's a broad topic, but we seek to provide specific and actionable tools to support this work. Next slide, please. This is a webinar format, so you are all muted during the webinar, but please do, and many of you are already doing this, use chat to say hello, to communicate, to ask questions, to raise ideas. Hello. If you would like to chat with the whole group of us, and there are several hundred on this afternoon or morning, depending on where you are, be sure that you select everyone in the panel just next to the chat box. We may not have much time for Q&A in this webinar because we have so many wonderful panelists, but we will do our best to respond to questions in chat and to provide written responses to questions that we don't get to. This webinar is being live captioned in English, and there are live interpretation services available in Spanish. Sashka will place instructions into chat, and I will also read them. Se puede acceder a la interpretación en español en vivo haciendo clic en el botón interpretation en la parte inferior de la pantalla de Zoom, icono del mundo. Una vez al canal español, por favor silencie el audio original. And we have just a couple of polls in this webinar, one in a moment and one at the end, and we would appreciate your interaction. Next slide, please. You are always welcome to reach out to us at ncaps@hsri.org. We are all busy facilitating this webinar, so won't respond to emails during the webinar, but we will certainly respond after. And as always, the recording, the PDF version of the slides, and a plain language summary will be available on our website, ncaps.acl.gov, in a few weeks. Next slide, please. Okay, let's find out who is here. I can tell from chat that people are here from all across the country, but we'd like to know in what roles you self-identify, and you may select all that apply here. So in the poll that has come up for you, please identify how you, for us what perspective you're representing: a person with a disability or someone who uses long-term services and supports, a family member or a loved one, a self-advocate or advocate, peer specialist or peer mentor, a social worker, counselor, or care manager, a researcher or analyst, a provider organization employee, or a government employee, or I should say, and or. And always there are identities that are not represented in these in this list. So please share your identity in chat. It's always wonderful to know who's with us today. I will leave the poll open for another 5 seconds or so, and then we'll close it out. Okay. Oh, response is still coming in. All right, great participation, everybody. Thank you. You can go ahead and close the poll now and show the results. Great. I am seeing that about 40% of you identify as social workers, counselors, or care managers. And we have a good number of folks spread across the other categories as well. And I'm sure many of you have multiple identities. And thank you for all of the additional descriptions you're providing in chat. Thank you. It's great to know who's here. Next slide, please. All right, it's time to meet our speakers. A little later this hour, you will hear from Bati Fong. Bati is a self-advocate living in Hawaii who has a learning disability and cerebral palsy. She is a college student who's very active in her community and is the president of the self-advocacy program for her Developmental Disabilities Council, and she works on emergency preparedness for people with disabilities. Later, you will also hear from Hector Manuel Ramirez, who is a Chiricahua, Apache, and Mexican autistic person who is hard of hearing and has a psychiatric disability. Hector does local, state, and federal level policy work in the areas of equity and disparities, and is on the board of directors with Disability Rights California and the National Disability Rights Network. Rebecca Torres is an artist, filmmaker, and disability advocate. After being paralyzed in a car accident as a teenager, Rebecca started a nonprofit called Backbones after realizing that years of interaction and friendship with others living with spinal injuries made a significant impact on her own life. We have two researchers here today who you'll hear from to start. You will hear from Tony Sadler, who is a postdoctoral fellow in health services and outcomes research at Northwestern University and the Center for Rehabilitation Outcomes Research at Shirley Ryan AbilityLab. Her research focuses on disability health services and policies that affect people with disabilities and their families throughout the life course. And to begin with, I will pass things over to Lindsay Du Bois, who is the project manager for the Rehabilitation and Research Training Center on Home and Community-Based Services Outcomes, Research and Measurement. And Lindsay has more than 10 years of experience in disability research, and her emphasis is on monitoring and evaluation of health inequities for people with disabilities. So with that, I will turn things over to our partner, Lindsay Du Bois, to share out about her work.
Thank you so much for the introductions, Bevan. So my name is Lindsay Du Bois. I am a white woman in my mid-30s. I wear glasses. I have shoulder-length blonde hair. I am wearing a pastel pink shirt. My background is blurred, but you'll see sort of blurry pictures and drawings behind me. And my pronouns are she, her. So we are really delighted today to be here and to speak with you about promoting meaningful person-centered practices in home and community-based service delivery. We can move to our next slide. And actually we'll go one more straight to the agenda. Thank you. So today, my colleague Tony Sadler and I will go over some of the research we have been doing on person-centered home and community-based services. We'll start with some background, then describe our project goals, our project methods, some preliminary results, and then this will lead us into our panel discussion. We could go to the next slide, please. So the Center for Rehabilitation Outcomes Research is at the Shirley Ryan AbilityLab in Chicago, Illinois. And we're conducting this work, and we just started the third year of our grant. The funding for this project comes from the National Institute on Disability, Independent Living, and Rehabilitation Research. Next slide, please. So I know that many folks on this webinar are probably quite familiar with home and community-based services, but I always like to start with that 10,000-foot view of what are HCBS, what are the scope of HCBS. So HCBS are health-related and social services that assist people with disabilities and older adults in living independently in the community. So HCBS can provide supports for employment, transportation, home care or home health, supports for activities of daily living and personal care, financial or budgeting support, and assistive technology or home modifications, to name a few. HCBS are most often paid for by health insurance, and Medicaid is the main payer of HCBS. And in 2018, there were more than 4.7 million people in the United States receiving Medicaid-funded HCBS. There are also sometimes very long waiting lists for HCBS, depending on what state you live in, or what group of people you might represent. The other important thing to know about HCBS is that each state has a slightly different or sometimes very different system. So as part of sort of state flexibility around Medicaid and HCBS, states can choose which populations to offer, which types of HCBS to offer through the use of Medicaid waivers. And then many states, cover HCBS for people with intellectual and developmental disabilities and those with physical disabilities. Other states might also offer HCBS to people with serious mental illness. And then there are some other groups that might receive services on waivers as well, but every state looks a little different. So if I can go to the next slide and talk a little bit more about the workforce, since quite a bit of our work is focused on this aspect of HCBS. So I mentioned that almost 5 million people use Medicaid-funded HCBS. So to meet that, pretty significant need, there is a really large workforce of home and community-based service providers. And there's a lot of different types of providers. So, HCBS are provided by individuals or sometimes groups of providers in an organization. And then there's many different types with sort of different specialties, different jobs. Sometimes they serve different individuals or different populations. So the figure on this slide is kind of intended to think about the workforce as kind of a system. So you have the HCBS user at the center of the system. And the next level of the system are the different providers who deliver direct supports. So those are folks who interact with people using HCBS on a regular, often daily basis. So this would include direct care workers, sometimes behavioral specialists or recovery aides, sometimes PTs, OTs. It really depends on the person and the services they're receiving. Another important group in this direct support are family members. They are an essential backbone of the HCBS system. And one of the reasons that HCBS tends to be quite successful and sometimes more affordable is because of those informal supports. Some states do have options to pay family members for supports. However, many family members are not paid, and that's probably another topic for another day. And then the next level that we kind of have categorized and used to think about supports is that outer level or the indirect supports level. In this level, you have the workers who may not interact with people who use services as regularly, but they are still really vital to making sure that we have the service system we need to meet the needs of users. And so examples here would be, caseworkers or care managers, the supervisors of direct support professionals, state coordinators, and others. So when taken as a whole, when we think about the workforce as a whole, there's really a tremendous number of people supporting individuals who use HCBS and kind of thinking about the different roles that they have. We can go to the next slide. The other important thing I wanted to mention about the HCBS workforce is something that comes up a lot, and it's the crisis in kind of recruiting new quality providers, retaining sufficient numbers of providers to meet the needs of the population. And of course, COVID-19 really amplified this crisis further. So this slide has some data from HSRI's staff stability survey, which showed that in 2020, there was an average turnover rate of 43%. There's also some data here from PHI National showing that in the last 10 or so years, there was a significant increase in direct care jobs added as a result of people aging and that the boomer generation aging. And then when we look forward to the next 10 or so years, they're estimating that demand will continue to increase. And then as a result of those high rates of turnover, there would be an estimated 7.9 million openings in direct care over the next 10 or so years. So this is kind of staggering. And the reason that this matters so much is because these high rates of turnover, the high rates of vacancy, it really contributes in a major way to people not getting person-centered supports. On the next slide, I wanted to just highlight the person-centered federal requirements from the HCBS final settings rule, because this is another influence for whether or not people are receiving person-centered supports. The CMS passed this regulation in 2014, and the compliance for this rule goes into effect next year. And the rule requires a few things, but the ones I wanted to highlight are two things: the requirement that every state ensures that HCBS meets minimum standards for integration, access to community life, choice, and autonomy. And that's going to be really important to our discussion later. And then the second thing is that every person who uses HCBS should have a person-centered plan. So the final piece of background information I wanted to cover is on our next slide. And this is some data from the National Core Indicators and the National Core Indicators Aging and Disability. And it's showing us a little bit about what we know about the outcomes of people who use HCBS right now. And so from this data, we see that 91% of people will say that their services and supports are helping them to have a good life. And 89% say that their staff have the right training to meet their needs. So that's quite promising. But where we see room for improvement is in how well services meet all the needs and goals currently for users. So that's only about 72%. And this is where we feel like person-centered supports could be a really wonderful solution if we do it right. So the project that we're leading, if we can go to the next slide, is focused on figuring out those key ingredients or competencies that are needed to have an HCBS workforce that's really skilled in delivering person-centered supports. So to do this, we have interviewed about 20 people who either deliver, oversee, or are involved in payment for HCBS, and 20 people who use HCBS. And we're looking to get their opinions on the skills that are needed, examples of times they've gotten those person-centered supports and times where they haven't, so that we can really kind of package that with other best practices that we know about. And after we complete analysis of the interviews, we'll have a framework of those key ingredients or competencies, and we'll be able to do some case studies with HCBS provider organizations that are doing a really great job of delivering person-centered supports. So that's kind of the objective and the next steps for our work. And I will hand it off to Tony now to talk more about the methods and the results.
Thank you so much, Lindsay. And thank you everyone for being on today. Before I start, I'll just give a little visual description of myself. I'm a white female in my 30s. I have medium length brown hair. I have a black cardigan on, and I have a necklace that's supposed to somehow balance my mind and body, but we'll see how that works. So I'm going to kind of take off from where Lindsay started and talk more about what we're finding and what we're hearing from folks who are, at the ground level implementing and receiving home and community-based services. So I'll start broadly with just our sample, and I just want to emphasize too, before I kind of go through some of the early findings, these are early findings. We're actually still in the process of interviewing, and the findings that I'll be presenting today are from about 40 recipients of HCBS, as well as providers of HCBS. So we've sought to have a diversity in our sample in terms of disability, race, ethnicity, HCBS services provided, and geographical representation. We started interviews with convenience and purposive sampling methods based on nominations from multiple partners that we've worked with, as well as advisory boards, participant council. We also have a participant council of folks with disabilities, And then from there, we've also incorporated snowball sampling techniques to recruit folks that provide and experience or receive or use home and community-based services. And we've also put an emphasis on talking to folks that have been recognized in their excellence in providing services. So that is another focus that we've something that we focused on. So next slide, please. Okay, so like I said, so we have demographic information from about 27 participants, but I'll be presenting qualitative data from about 36 participants, but I'll reiterate that. So currently for our statistical demographics, we have 12 providers and 15 users. Most of the participants are female. We do have 5 male participants and 3 non-binary participants. And then the average age of providers is 49 and average age of users is 44. Okay, next slide, please. So most of our participants are white, but we are continuing to seek out diverse participants for these interviews. We do have representation of Asian, African American, American Indian, and Latinx participants as well, both on the HCBS user and HCBS provider side. And then just to note also, we are actually targeting some of our future recruitment efforts to make sure where we don't have good representation, that we are finding folks that we can talk to that can help fill those gaps. So next slide. Okay, so in terms of disability for folks that receive home and community-based services, currently we have folks that have a mental health related disability, intellectual developmental disability, or physical disability, or both, or multiple disabilities, sorry. Currently, we are also targeting interviews for folks with age-related disabilities as well. Okay, next slide, please. And then in terms of our providers, I just want to note that the providers represent multiple levels of providers. So folks at the state level who are, coordinating services for their state, also managed care organizations are also represented in this group, but the vast majority are folks that are either directly providing services or like our organizational leaders, like the director of day service programs, something like that. And over 90% of our providers have over 5 years of experience, and then we have quite a few with much more than that. So it's been really interesting to talk to folks about the evolution of person-centered planning and practices and how things have changed over time as well. All right, next slide, please. Okay, so again, today I'm just going to talk about some of the early findings, and I'm not going to talk too much because we would like to most of the time to be devoted to our panel. And we can also answer, specific questions about the research we're conducting, either, via email or if we do have time for questions at the end. But today I'll be focusing most of the early findings on competencies of person-centered practices in HCBS. So NCAPS has been very helpful and generous in helping us start our research with a framework. And so today, in terms of what we'll be talking about, our participants and interview respondents' experiences with choice and control and dignity of risk. If we have time, I'll also touch on some organization and training considerations. And then I will talk a little bit about COVID-19 as well, and how that has impacted person-centered planning and practices. Okay, next slide, please. Okay, so this slide, I think kind of helps at least me think about what, you know, these interviews were trying to get at, and you know, we have a lot of understanding about person-centered, you know, policies. We know about the final setting rule. There are a lot of resources for person-centered planning and person-centered training out there. We've actually done some systematic reviews on those types of things. But one kind of gap that we've seen is how are these person-centered practices being implemented, and then does that implementation then lead to outcomes in terms of person-centered outcomes, quality outcomes. So I just want to emphasize the interviews were really trying to get at how individuals experience services at the ground level, and talk a little bit about some of, you know, possibly the barriers and facilitators associated with providing good person-centered planning and practices. Okay, next slide, please. Okay, so on this slide, there are a lot of words, but I'm going to talk you through this and touch on the key elements that we think are important to highlight. So here is a chart that displays facilitators of choice and control and barriers to achieving choice and control based on our early findings from interviews. And we have this split up between provider perceptions and recipient or users of HCBS perceptions. So first, facilitators of choice and control from a provider or state leader perspective often focused a lot on administrative and structural elements, including, you know, are we doing enough in staff training? Are we auditing and documenting person-centered practices so we can improve on them? And also interest in interventions such as, you know, harm reduction when discussing things like dignity of risk or motivational interviewing. So at the provider level, a lot of the facilitators that were identified for choice and control were kind of at the organizational level and included, you know, structurally how to implement and achieve those goals. On the contrary, from you know, users of HCBS, folks that utilize these services, we had a very different perspective of what, you know, facilitators of choice and control are. And from perspectives of those who receive these services, facilitators of choice and control often focused on distinguishing between meaningful and significant choice and control from more performative forms of choice and control. And one element includes choice and control of, you know, choosing and hiring staff. That was something that was identified as very important to multiple folks. When it came to goal setting and planning meetings, some people who received HCBS desired more of a leadership role rather than just kind of being a part of that process or helping facilitate, but really leading that process. Excuse me. And then another topic that was brought up by people who received services were transparency of goals and transparency of the planning around. So really having a collaborative effort with organizations to plan out their goals in their lives, but also having transparency of how organizations are keeping that information, being able to contribute and change those documents. That was also another important thing. Some people stated that they did not have access to their plans and notes, and that definitely was a barrier. Another important facilitator to choice and control was not just choice and control over, activities and goals and things you do in the day, but the time that you do them and how you do them. So being able to have flexibility to cancel things and to change your schedule and to do the things that you want to do when you want to do them. So that was also something that was very much emphasized by people who receive services. And then when it came to barriers of choice and control, there were several overlapping themes from both providers and people who receive services. As Lindsay mentioned, the workforce crisis and high turnover rates of direct support workers was mentioned in virtually every interview that we talked about, often unprompted. So this is I think a lot of folks here today will resonate with this, that it's a very serious issue, and I know that there's a lot of work being done right now to try to amend some of these challenges. But when you have such an unstable workforce, folks that receive services have noted that your choices really become constrained. One with who provides services to you, but also the types of supports that are available to them. So that really constrains choice and control. Another comment or barrier to achieving choice and control were choices that were constrained by the environment or the organization itself. And by the environment, that could mean something as macro as, folks who are lived in a rural environment might have a much smaller choice architecture than those who, had more access or choices within an urban environment. And then that could also mean choices within an organization, and the types of services that they provide. There might not be a lot of choice within the constraints of the services being provided. And then recipients of HCBS also discussed quality of services and how services that may have lacked quality or from their perspective really was a barrier for their choice and control in their lives. Okay, next slide, please. Okay, so I went over just a lot of content overviewing how providers and recipients of HCBS perceive some of the barriers and facilitators to choice and control. But I just wanted to provide a few quick examples. I don't want to go too deep into this because we have folks here that will be able to speak to some of these things as well. But in terms of organizational or bureaucratic barriers, we had one individual state that sometimes services make me feel trapped. Another person stated services are a barrier to facilitating rights and choice and control. And obviously this, depended on the person being interviewed and the types of services, they were receiving at the time, but sometimes the constraints within the service provision often limited their choice and control in their actual daily lived lives. In terms of choice and control over time, when asked, what does choice and control mean to you? One respondent stated, being able to decide what time I want to get out of bed in the morning, if I want to take a shower or not, what food I want to eat, time I want to go out. So really an emphasis on time, and that was brought up several times. And then in terms of distinguishing between meaningful choice and not just choice as kind of performance, One individual said, I don't get to make choices, but I have input into choices that are available. So that was definitely, a theme that was brought up among folks that receive services, that, even if there are choices, are they meaningful to me? Is it what I really want, or is it just what's available? And then finally, in terms of leadership, one individual exclaimed, "My choice, my way." And then to paraphrase, "These are my goals, but I need your help to accomplish them." So those are just some examples to kind of touch on some of the themes that I discussed in the previous slide. Okay, can I go on to the next slide, please? And actually, I'm going to skip forward to the next slide. Great. So I just didn't want to miss out on a little bit of a discussion on COVID-19. So, in our interviews, we definitely leave space to talk about COVID-19. This is not an afterthought. This is very much integrated into, the conversations that we have with folks, and also just how we're going to move forward in research and policy in addressing some of these challenges. So some of the themes that stood out when discussing COVID-19 and person-centered planning and practices were hiring and retention. Also, in-person versus virtual. So in terms of hiring and retention, most of the organizations, probably all of the organizations that we talked to noticed a pretty significant drop in either losing employees or difficulty finding them. And this was already, a problem that they were facing. And then in terms of in-person versus virtual, folks that were, just transitioning from in-person services to virtual, we heard a lot of success stories of organizations really just, not skipping a beat and really doing everything they can to meet, their clients. But we also heard the flip side where folks that were receiving services really felt left behind, or services completely stopped. And then I just want to also mention, we heard a lot of wonderful stories about, resiliency and charity and just creative ways of trying to get through this crisis together. And so I'm actually going to end this portion of the presentation. We just wanted to share some of our initial findings. Nevada, who works with us, is going to put some links in the chat so you can learn more about some of the work. But now I want to focus on our panelists today, and hopefully facilitate a wonderful conversation with them about their experiences receiving home and community-based services, but also just, their life experiences focused on things like choice and control. So I will hand it back off to Lindsay to kind of start that conversation off.
Thank you, Tony. So if we could have Bati, Hector, and Rebecca turn their cameras on. Thank you. And we, if we could have you all introduce yourselves, can we start with Hector, please?
Yes, thank you very much for having me here today. My name is Hector Ramirez. I am a Chiricahua Apache and Mexican. My pronouns are they, them. I am coming to you today from the unceded lands of the San Gabrielino Band of Mission Indians, which is Los Angeles. Brief visual description for my background. I'm using a background that shows a field of flowers with the sun setting, and a corner logo for the California Memorial Project, which is a project that we have in California that commemorates the number of people that have died in state hospital and developmental centers because they couldn't live in the communities. And so this is an event we have once a year. I have a red T-shirt with the United Farm Workers logo. I'm always an advocate. All my clothes has a cause, and I am 47 years old, and my hair is pulled back in a ponytail. Thank you.
Thank you, Hector. Back, Rebecca, could you please introduce yourself?
Thank you for having me. My name is Rebecca Torres. I am a Mexican-American woman with brown skin, brown shoulder length hair. Today I'm wearing a teal sweater and I'm in my office with black cabinets behind me. I am also a person with a disability from a spinal cord injury at the cervical level, and I have used a power wheelchair and HCBS services for a very, very long time. So thank you for having me.
Thank you. And last but not least, Buffy.
Aloha, everyone. Can everybody hear me?
Yes.
I am Bathy Fong. I'm a person with a disability. I have a learning disability and also visual palsy. I use a walker and also a wheelchair, and I live in a foster home. So I live in a group home here in Hawaii, and also I am a college student, and I also participate in a lot of things in the community here in Hawaii, and I'm a emergency preparedness with people with disability, and also a DD council member, and I'm a SAC president for the self advocacy program with people with disability, and also a TEC impact trainer for people with disability. And I'm wearing a aloha shirt, and in my background I'm in the living room. So thank you for inviting me.
Thank you. So for our first question, we wanted to hear from each of you directly about sort of the fundamental question of our work, which is, what do person-centered supports mean to people who use HCBS? So if we could hear from Bathy and then Hector and then Rebecca, I will hand it off to you guys.
Can you actually put it in another way so I can understand what is the question, please? Thank you.
Absolutely. So researchers might think that they know what person-centered supports are, or people who deliver services might know what person-centered supports are through training, but sometimes people who use services might have a different idea of what that means. So we think it's important to hear from as many people who use services as we can about what they think person-centered supports are.
So person-centered services to me, it actually in the beginning it didn't work for me really well, because I actually didn't really have a voice for myself. I let other people have a voice for me. So I didn't make a lot of choices for myself before. So it's a really challenging for me to have a voice in a lot of things before, because people will make a lot of choices, and it was a very um, difficult thing to have a life that I want. But now a lot of things that has been changing since before. Now I can make choices now. Um, um, Things that I want in life, but um, it's also very easy now for me to have choices that I want, and um, people will support me, but I will make the the choices on my own. But- And it's very hard for me to figure out what I want in my life and what is a good life for me. But it's a it's a very challenge thing to do all the time.
Thank you, Bathy.
Yeah.
I appreciated hearing you talk about kind of the journey, and person-centered supports is constantly there, and there are times where it comes more naturally and times where it doesn't. So thank you for sharing your experience. Can we hear from Hector, please?
Thank you. Person-centered, nothing about us without us. Let's just start off with that. I come from a state hospital developmental center, and I remember being there, and all of our choices and decisions were made by other people. When we had to get up, when we ate, where we went, everything literally was made by us. And when I came out of the state developmental center, it was pretty interesting to know, first of all, that there were a lot of choices that could be made. I was still underage, but then as I became of age, I had the opportunity to make every single choice that I wanted without having to ask for somebody's permission, or having it to get approved, or having to do a form. And then when it came to getting services, it wasn't that. So I think that's what I wanted. I see me, and then the services that I need or want around me. That's what I think of person-centered. Everything about me, with me. And it seems like such a radical thing for some people, but that's what most people do every day. And that's kind of what I think of it for this particular conversation.
Thank you. And Hector, if I could probe just a little bit about some conversations I know you and I have had about making person-centered supports more culturally appropriate and inclusive, and even the term person-centered and things like that. So I don't know if you want to take a little time to speak to that now as well.
No, thank you. I think for allowing me to go into this further. As a Native person, when it was interesting coming into this with this kind of new ability to make choices, and as a Native person, I was always really encouraged, like, to be independent, live independently, move away from my family, like a lot of my peers as they were getting older. And it really seemed like that's what person-centered was, because that's what people told me that it was. And so I wanted to really follow along in this journey. But I think for me, I realized that person-centered really meant community, family. My family, first of all, being able to go back to my family was a big thing. And in our family, in our community, we make our decisions based on each other, and we share with each other. So I think for me, it's been a journey of kind of realizing what that is. First, not having a choice, then having all the choices that people told me, and then actually like realizing what my choices were. So for me, like, a lot of my person-centered services are really based around my family, my community, because I lived on my own for, I think, 2 years. That's as long as I've ever lived on my own. And I moved away from my family to be independent like I was supposed to, but that was really hard. That was really, really hard. Actually very depressing to be away from my family. And I think for me, the thing that helped me, was really kind of looking to see how person-centered really was, like, in a collective community, where my family, I'm fortunate that my family and my culture are supportive, and to the degree that they can, and that I'm able to really be in that space independently. I have my own place, but I'm with my family. And I think that's another way, of how person-centered was a little bit different. There's kind of like the Western idea of what person-centered is, and then all of us, based on our family culture or ethnic culture, sometimes, that definition, is different. For mine, it's historical. We are collective communities. Even people with disabilities, we have roles in my tribe. So that came into play later on as I really had to really think about the different types of person-centered, and you have that choice too.
Thank you, Hector. That was a lot of really important points that you touched on, and how it can be very different to different people, which is why we're really grateful to hear from you all and to be able to talk to so many different folks in the community and hear those different perspectives. So Rebecca, can I ask you to share kind of your perspective then on what person-centered supports are?
Yeah, I really appreciate what both Bathy and Hector have mentioned already. And this idea of community, and like we're talking about, person-centered care in our communities. And there's so much interdependence that happens in the life of someone with a disability, because we do depend on a lot of people to help us be productive or functional or independent in our lives. To me, having person-centered care is me being in control of what happens with my life, whether that is directing my care in the morning when someone is helping me get in and out of bed, or bathing, or getting dressed. It means that I get a say on what my care plan looks like with my case managers. It means I have discussions with my family of like how I need them to support me, or how I need them to back off when I need them to. So it, like Hector said, nothing about us without us. And I think it can easily be lost where, there are these systems with so many layers of things that need to happen for our lives to be in the quality of life that we want. And it can easily be lost where we are the center of that and we are being able to direct that.
Absolutely. Thank you for sharing, Rebecca. And you touched on this a little bit in your response. So I'll move to the next question we have, which is kind of thinking more about this emphasis on equity that we're seeing across a lot of different systems, and in particular, the HCBS long-term services and supports system. And so the emphasis on what do we know about outcomes for people from different communities. And we know that the disability community is just incredibly diverse. There are a lot of intersecting identities that people hold. And so, person-centered supports does mean a lot of different things, but person-centered supports is also an opportunity to drive the conversations and the actions around equity. So I wanted to ask first, Hector, if you would touch on kind of how you think person-centered supports can be driving conversations and actions around equity for people who use HCBS.
Well, definitely, you look at the people that receive the services, and I mean, just look at the times. We're still in COVID times. It's not, the pandemic hasn't ended, and we know, for example, that since the pandemic started, we have seen that individuals living in congregate settings had the worst health outcomes during this pandemic. And if there was ever further truth that people with disabilities are safer when they live independently or supported in their homes rather than in congregate settings, that we live longer. It's so sad. In our family, when COVID hit, we had a lot of first responders, and we also had a lot of people with disabilities in our families. And the overall casualty that we saw in our family, we lost 7 of our people, disabled people, and they all did not really survive because they were in congregate settings where they couldn't get the services that they wanted, that they needed when they needed them. And then it's just really shows some of the inequities that are very much in the system already. And then you add, for example, some of the really built biases that are built into the systems. to really make it more difficult for people of color to get community services that are appropriate, what we want, and safe. Um, it's who we're letting into our home, who we're letting into our families, not just having to worry about whether or not we're going to be safe from COVID, but whether or not we might be safe, from who they are or with the type of services that they have. I'll share, aside from getting services for myself, my brother also had services, and I speak to him in the past tense because he was one of the people that passed, and he was a long-term AIDS survivor, living in his own place, and we couldn't find anybody to help him, and we got services at home because we had to bring him home, and some of the stuff that we would get was just not appropriate. It wasn't safe. As a two-spirit person, gay person himself, it was hard. In one occasion when we got one particular, worker who came from a faith background that was very homophobic towards my brother, and in his time of need, in anybody's times of need for just services, that should not be another thing to have to battle at home. And when we talk about equity, we talk about availability of services in the community, and not really sometimes having the option of choosing who's going to come into your door. And that's a very vulnerable situation, specifically when you have people that really depend on services. And that's what equity really has kind of highlighted in this whole ecosystem, the significant failures. It's almost like it's a punishment for people that want to live independently, and they're supposed to have services, but if they get those services, oftentimes they're not the appropriate ones. And this is where we live. It's almost like, I don't want to put it so, but it's almost like you're bringing sometimes an enemy inside, and so it feels so scary sometimes. And it's not something that should happen at home or anywhere when people are getting services. Did that make sense?
Yeah, I think, the points you made around we've suspected the inequities for a long time, and COVID-19 in particular really put a spotlight on data showing that those inequities were just incredibly pervasive, and really baked into the system. And so, going from here, using that data to really think through how systems can better serve all people, and how different approaches are needed to serve different people. And I think you touched on quite a bit of that, Hector. So if I could ask Rebecca to kind of respond to the same question about, how you think person-centered supports can drive these conversations that are happening at that national level around, how should we address equity and these issues?
Well, like I mentioned earlier, I have been receiving services for a long time, for over like 25 years. I was injured as a teenager, and it isn't until this year or last year that I have heard us giving input on how this should be. And someone in the chat earlier said, there's data collected about who makes these decisions and their race, but is there data about how many people with disabilities had a voice in creating and shaping these services and these programs that are for us? And I think that is a big indicator of like how much our voice is missing from this. And it's important to have these conversations. It's important to start collecting data to call out when it's not working, when the system isn't working, and we need to call it out, and we need to try and find solutions, because there is a lot of fear. As Hector mentioned, there's just fear, not even like in the day-to-day moments where you may be in a situation that's dangerous and you're fearing that that you're not getting the right care or that you're in danger. But there's also I've experienced fear in speaking up about some of these things, because maybe I might lose my services, or if I say something like, and it shouldn't be that way. we should feel safe in being able to talk about these things and being able to help our community and help those who are our allies and who are in those like in the positions of being like a case manager or something like that, or the ones that make these decisions, to just be aware of like what exactly are the needs of the community, so that the right choices can be made and the right decisions can be made.
Absolutely. And I think the points that you, Hector and Rebecca, both touched on in terms of fear of losing services is something that we did hear across the board. And I think that's really important for the system to address. There's both, what is the reality, but what is the perception? And those two things are both important when thinking about equitable solutions to ensure people have equitable access to services. So Bothy, is there anything that you would add to the comments that Hector and Rebecca shared in terms of how person-centered supports can drive these conversations?
I really agree, because every state is very different. So where I live, person center, here in Hawaii, it for me, I look with other people with disability. It works for other people with disability, but it won't work for other people with disability, because when here in Hawaii, when we have when we want services from the case manager, and they look at some of our disability, they say, oh, you don't have a disability, so you don't, you cannot receive services. But for me, I still kind of learning that everybody needs to have services, but it's when we cannot have services, we always have to find a way to make our life very more happy, and to find things that we can do if we don't qualify for services with what the case manager wanted us to have in our life. So I kind of see it every day here where I live. So the services, some of the people with disability, they have a hard time speaking up for themselves. And we also, even though we have a disability, people, we always have to support one another to have a voice.
Yeah, Hector, please.
And I think I really want to thank Buddy for uplifting that we have to really sometimes advocate for our own. And I think for me, one of the reasons that my family is important is because they back me up in those circumstances. Because I know what that is like, to have services canceled or the retaliation for speaking up and not really knowing where to go to speak up and having things done. It's something that we see. I'm in California, where we have like lots of funding. We have like the leading disability agency in the country, but we still have cases like this on a regular basis. I think right now, for example, one of our leading advocates, national disability advocates, Alice Wong, who just has been elevating so much work for the disabled community. She's nationally recognized, and a couple of months ago, she had to go into the hospital, and because her disability needs are higher for her, and there was no services. And I mean, she's like an advocate, and the only choice that they gave her, she has a home and family, she just needed support, and she just needed more support. Is like, here you have somebody who's nationally recognized, and the only choice that she was given is to move into a boarding care facility or a long-term care facility, because there was nothing for her at home. And this is California, 2022. And it's like, and our community had to kind of rally, and it's still rallying, to kind of like help. Here you have the leading disability rights advocate, and we're all having to like advocate to help her on something like this. And I think that just really kind of highlights the biggest state with the most resources, and you have this example of just how the system is really blindsided, if sorry for the term, but blindsided to really the impact and the needs that our community has. And how there's really very little, if any, place for folks to go get help in a safe way, because we're not at the table. It's everything about us without us right now.
Yeah, I hear all of you touching on the sort of constant advocacy, both individually, collectively as a community, and that's a constant presence. And I can imagine that may sometimes feel like a burden as well, to kind of have to repeat your needs constantly and feel like, well, why should I be having to ask for this a lot? And certainly quite a bit of room for improvement in the system to make sure that that's not such a constant presence there. So I kind of want to move to the next question, which is to think a little bit more about person-centered planning. Is one of the things that we heard from folks is, that person-centered plans, even though, they might be designed really well and they might be really person-centered, sometimes they are actually a barrier. It's just one more barrier to people having the lives they want. So I wondered if each of you could speak a little bit about how your services and your providers have, supported your rights and ensured that you have choice and control with your services, not just about those big things specified in your service plan, but even on that day-to-day basis. So if we could start with Rebecca, and if you could answer that for our audience.
Yeah, I have had some really great caseworkers over the years, and then some not so great. And they're sometimes you see them more often, and sometimes it's just once a year when they come in and they say, like, I'm here to do a reassessment. And it feels like checking off boxes and wanting to know all of the very intimate details of your life that can sometimes seem very, very invasive. And then they go away and they make a plan and they say, these are how many hours you have, and you don't know how they got to that amount of hours that you need or are allowed to get to services in your home. So yeah, I think that I've had, like I said, I've had some really good care workers or case managers that have really helped me, get the right amount of care that I need in my home. And but yeah, I think sometimes what can be lacking is like kind of knowing what's next, or somebody mentioned earlier, like, where's my care plan, where you don't see it for many, many months before, and you're not really sure what's going on. And I think that oftentimes, it's the caseworkers might have just a lot of cases that they might not get to you. And but it's still like, I don't know, sometimes it feels like that shouldn't be an excuse. Like, we need to be seen as like whole people, and having all the information about our care and what needs to happen for us to get the appropriate care. I'm not sure if that answers your question, but
yes, absolutely. And I know, Bothy, it looks like you're prepared to share your perspective as well.
Yeah, I think I have the same, because over the years it's been crazy in my life, because I've been actually changing case manager. Some were not supported, some were supported. The things that I want in life, and even the homes that I've been living in, some were not, some were it. But I learned during the years of to have a good life is to find the right people to support you in your in my life. And um I like the services that I have now, even though I have um, um, little bit services. But one thing that I learned in past years is like uh, my my provider and my case manager and my circle of support get to hear how I feel in my life and to have what kind of good life that I want for my own. So it really helps me to to have a good services that I want in my life. So it's for me. I have be thankful that all the service that I have now, it's been working for me because it it made my life more happier than before.
Yeah, thank you for sharing, Bothy. It's great to hear that they're, from what you're sharing, it sounds like they're working really well for you now, but there was a lot of work on your part to, get the person-centered supports you need. So thank you for sharing that. And Hector, could I ask you to kind of share your perspective about how services and providers have supported your rights and ensured you have choice and control, and maybe some examples of that?
Well, yeah, actually, the best staff that I've had, she was so good that she got fired for it, because she taught me how to advocate for my person-centered choices. I wanted to go home to my family community, and everybody really, in their best interest, they wanted to keep me independently out in the community, and I wanted something different, and people felt that I was going backwards. I don't know, that's really what it felt like, and this particular staff, I think for me was helpful because she really kind of helped me understand not only how things could be, not how they should be. And it's almost like she kind of like moved the curtain so that I could see how things worked. And that's when I really had a better understanding of, you know, how what I needed to do to try to get the things that I needed. And so I realized that, she explained to me my rights, which was like, wow, okay, thank you. That was like really, really good. And she explained to me after I asked many, many questions. And how to really enforce those. I think that to me has been like one of my biggest kind of services. Because I used to be very non-confrontational and would just go along, and now I'm more willing to really speak up, and not worry about the tone that I'm using, because of why I'm doing it. But then I also understood that, sometimes just following a chain of command doesn't always work, and I thought that's how it worked. And sometimes you have to do kind of systemic work or systemic advocacy to get the things that we need. And for that she lost her job because I wouldn't stop advocating, for that. After that, she was a great worker, and I've had really, really fantastic folks, and some that I was really glad to go away. I mentioned the experience with my brother, but I think at home, I had two other, because I never get to I've never get to choose who comes in, and I had two cases where we had two individuals, separate individuals with different faith backgrounds, and they would come into my home, and one of them was from a Catholic faith, and for a family, there's a lot of generational trauma with the Catholic Church, and I was a survivor as well, and that was a very difficult thing because she thought that it was appropriate for her like to pray for us or things like that, and me and my family were very uncomfortable with that. That was one example. Similarly with another one, I think it really has come back to individuals, not necessarily that don't know how to do the basic job, but how they do it, the cultural context of it. It's like we all like to eat, right? We all like hamburgers, but we all like different types of hamburgers, and we go to different places for them for a reason. And I think, that's one simple way of kind of explaining. Sometimes, you wanna, I don't know, like McDonald's hamburger and somebody wants you to go eat, Burger King, and that's all they have. But and I don't eat fast food. I shouldn't say that. But just trying to kind of make it kind of put it in those terms. Does it make sense, Nancy? Did I say it correctly?
Yeah.
Nothing?
Yes.
Yeah.
Thank you. And I think that was a great example. But obviously not the outcome that you want when someone does a great job of supporting the rights and ensuring that people who use services have choice and control, and then they lose their job over it. So I hope she was able to be, I think you said she was able to continue working, but maybe for an organization that had some of those values, because those are exactly the types of people that we need more of in this space, so we can continue to improve services. So for our final 4 minutes here of the panel, I wanted us to do a thought experiment where we sort of imagine what it could be. And you kind of started to talk about this, Hector, when you said, not what it should be or what it's supposed to be, but what it could be. And I think that's an incredibly important kind of thing to think through. There's a lot of things that probably could be changed to make the system better reflect person-centered supports. But I'd be curious to hear from each of you, what you would change. So Hector, could I ask you to share first what you would change?
Thank you. I think definitely, well, I think what we're doing right now is speaking up. It's one of the things of having more opportunities for people to be heard, to be understood, to be validated and recognized for their experiences. But I think I've known that systemic change goes from the top down, and I think really gathering data that is centered, by the people that use the services, with an equitable lens to have diverse representation is important, because it comes down from the top down. Really having regulations and guidelines in place that are very well developed by the people that utilize the services. And I really do appreciate our policy folks and our researchers. I really, really do. But I think, really centering the work that they're doing around, the beneficiaries is important. Having them be part of the design, having them that had significant input into those regulations and how it's being kind of implemented down. Having us along with the process is very important. And I think recognizing the significant impact of not only having like first sources, which is what we are, you gather the data from us, you go write it, and then you tell us what you write about. They're like, no, like it's a different type of approach. So really having, the beneficiaries included intentionally, with a purpose from the top down is very important, so we can improve the services. We don't need to go back to that horrible normal that we had before. The pandemic has taught us so much. We owe it to all the people that we've lost and that we continue to lose to really try to make the system better. If not for them, then at least just as much as we can for our families and ourselves. But it's something that that really is cultural reckoning. We've lost around 1 million people, and many of them, could have been saved had they had supports when they needed them.
Yeah, absolutely. Bothy, could I ask you if you could change the system somehow, or what you would do to make home and community-based services more person-centered if you had an unlimited budget and everything you needed?
Are you talking to me?
Yes, Bothy, if you would share your
What is
perspective.
our question again? Sorry, I couldn't
Yeah,
hear.
that's okay. Yeah, so just thinking about kind of what Hector had mentioned around not necessarily what it should be, but what it could be, and not what it is, but what it could be. So if you were to create, reform or change the system to make it better reflect person-centered practices, what would you do?
For me is I want to see more people to have a good life and to actually have a better community, because since COVID everything has changed for people with disability. uh you know I feel like we need to um have more freedom for them since COVID has changed a lot with um, their life, and and uh, services has been changing and been always I mean, yeah, bring
Yeah.
bring back more life, good life for people with disability.
Mhm. Absolutely. And I know we're nearly out of time, but Rebecca, can I ask if there's anything that you would change, or many things that you might change, so that the system
Sure.
is really better designed?
Yeah, I'll have to agree with both Hector and Bati that what they said, but I also want to add that like something that stuck out to me was what Hector said, that someone sort of opened that curtain to show him that he had a voice, and same with Bati. She found her voice, and I think there's a lot of opportunity for support, not only like dollars at these programs for research and for supporting the services, but like supporting those who are receiving the care, supporting the direct workers. Like there's a lot of turnover because they aren't supported, they aren't getting good benefits, they aren't getting good pay, and so they need to be supported and empowered as well. So do the caseworkers who may be burnt out from doing this work. Like there just needs to be more support at every level, because like if we're going back to person-centered, all of these people are humans and people in different roles that do need the support in order for all of this to work successfully.
Yeah, great.
And
I'd
love to also somehow tap into this power of like mutual aid, like you said earlier about how we helped supporting Alice Wong to like get the stuff that she needed. Like we have a lot of power within our community, and how can we harness this like mutual aid power too?
Yeah. Yeah, excellent points. I know we need to wrap up now. So I just want to express my tremendous thanks to Hector, Rebecca, and Bati. Again, I reiterate how much I think research needs to do more to really understand, as you put it, Hector, the kind of the experience of folks. I think you said first, I can't remember exactly how you coined it, but yes. Yeah, so just thank you again for sharing. I think you all presented a lot for us to think about as we move forward with this work.
And this is Bevan. Thank you, Lindsay, for facilitating this panel, and to Lindsay, Tony, and team for introducing us to Hector and Rebecca and Bati, and for all the wisdom that you've dropped today. We are just thrilled, and you're getting lots of thanks in chat as well, because we've all, I think, really benefited from this conversation. A post-webinar evaluation poll has popped up, and we would be ever so grateful if you could please just click through and answer the 6 questions on this poll before we say goodbye. And just as a reminder, we are in a state of continuous quality improvement here at NCAPS. And so we're always open to ideas about how we can improve our webinars, how we can make them more accessible. And we're also open to ideas and requests for future webinar topics. So get in touch with us if you'd like, and stay in touch, and we will keep the conversation going. Thanks to everyone. Have a great evening or afternoon or morning, depending on where you're from.